Dysphagia. So definition: difficulty in swallowing is called dysphagia. Pain during swallowing is called duodenophagia. Duodenophagia is more marked in ulcerative and inflammatory lesions of the food passage, oral cavity, oropharynx, and esophagus. Come on to the etiology. So you can classify dysphagia into pre-esophageal causes, that is the oral phase of deglutition. The second one is the pharyngeal phase of deglutition in this, and also esophageal causes, where the luminal wall lesions and outside the wall lesions are the most common causes. So it is important to meet. It is important because most of these pre-esophageal causes can be easily excluded by physical examination, while esophageal causes require investigations. Pre-esophageal causes. The oral phase, normally food must be masticated, lubricated with saliva, converted into bolus by movements of the tongue against the hard palate. Any disturbances in these events can cause dysphagia. Disturbances in mastication, trismus, fracture of the mandible, tumor of the upper and the lower jaw, disorders of the TM joint. Disturbances in lubrication, xerostomia following radiotherapy, Mikulicz disease, disturbances in mobility of the tongue, paralysis of the tongue, painful ulcers, tongue tumors, lingual abscess, total glossectomies. Defects of palates, cleft palate, oronasal fistulas, lesions of the buccal cavity and the floor of the mouth, stomatitis, ulcerative lesions, Ludwig's angina. Pharyngeal phase. For normal swallowing, food should enter the pharynx and then directed towards the esophageal opening. All unwanted communication into the nasopharynx, larynx, oral cavity should be closed. So the obstructive lesions in the pharynx include tumors of the tonsil, soft palate. It can be of the pharynx, base of the tongue, supraglottic larynx, even the obstructive hypertrophic tonsils. The inflammatory conditions, usually acute tonsillitis, peritonsillar abscess, retro or peripharyngeal abscesses, acute or epiglottitis, edema of the larynx. Spasmodic conditions includes tetanus, rabies. Paralytic conditions include paralysis of the soft palate by diphtheria, bulbar palsy, cerebrovascular accidents cause regurgitation into the nose. Paralysis of the larynx gives rise to lesions of the vagus due to the lesions of the vagus nerve, and bilateral superior laryngeal nerve cause aspiration of the food into the larynx. Coming on to the esophageal causes, it can be obstruction into the lumen due to atresia or an impacted foreign body, stricture, benign or malignant tumor, wall. Hypomotility disorders, achalasia cardia, scleroderma, anterolateral sclerosis, hypermotility disorders, cricopharyngeal spasm, diffuse esophageal spasm outside the wall. It can be because of hypopharyngeal diverticulum, hiatus hernia, cervical osteophytes, thyroid lesions, enlarged tumors, Hashimoto's disease, mediastinal lesions, tumors of the mediastinum, lymph node enlargement, aortic aneurysm, carotid enlargement, vascular rings. So investigations include history, detailed, is important, sudden onset, suspect foreign body infection on a pre-existing stricture or malignancy, progressive malignancy. So then intermittent, you can expect spasmic or spasmodic episodes of the organic lesions. More to liquids than paralytic lesions, more to solids, and progressive even to liquids, malignant or strictures. Intolerance to food or fruit juices, ulcerative lesions. Associated symptoms can be regurgitations and heartburn. Think of hiatus hernia, regurgitation of undigested food while lying down with cough at night, hypopharyngeal diverticulum should be thought of. Aspiration into the lung, laryngeal paralysis should be thought of. Aspiration into the nose, palatal paralysis should be thought of. Clinical examination of the oral cavity, larynx, hypopharynx can exclude most of the causes of pre-esophageal dysphagia. Examination of the nose, chest, nervous system and the cranial nerves should also be done. Blood examination, hemogram is important in diagnosis and treatment of Plummer-Vinson syndrome to know the nutritional status of the patient. So X-rays help to exclude cerebrovascular accidents, pulmonary and mediastinal diseases. Lateral view of the neck includes to exclude cervical osteophytes, soft tissue lesions of the postcricoid or retropharyngeal abscess, barium swallow, malignancy, achalasia cordia, strictures, diverticulum, hiatus hernia, and esophageal spasms. Combined with fluoroscopic control or senior radiography, barium swallow can help in diagnosis of motility disorders of the esophageal wall and sphincters. So you can see a dilated esophagus over here. You can see a strictured esophagus in the middle with the tracheostomy tube in C2. You can also see strictured lower one third of the esophagus with dilatation. So manometric and pH studies, pressure transducers along with a pH electrode and then open tipped catheter is introduced into the esophagus to measure pressures in the esophagus and sphincters. Acid reflux measured by pH electrode. Motility disorders. Coming to esophagoscopy, you can do a flexible or a rigid esophagoscopy. Examination of esophageal mucosa directly or easy biopsy can be taken. Bronchoscopy for bronchial carcinomas, cardiac catheterizations, vascular analysis, and then thyroid scan for thyroid malignancies. Okay, coming on to the treatment part of it. So it is specific to the cause. So if the cause in the oropharynx, oral cavity, then treat the trismus with the oral lesions. If it is in the pharyngeal lesions, so if it is an inflammatory, go on for antibiotics, and then if it is a non-inflammatory conditions, and then give a definitive treatment for that. If it is in the bronchial, then go for a bronchial investigations, and then the abscess and should be treated, or the infection should be treated as a medical line of management, while tumor should be treated with anti-cancer drugs. Thank you.